Welcome to this week's lecture. We are going to continue on our journey with obesity. We'll talk a little bit more about obesity as well later in the semester, but I want to touch on pediatric obesity. This is a really important population that I want to make sure that we look at some of the socioeconomic stuff behind it as well. So these are just some ads, I think, that are really potent. We could spend a lot of time digging through newspaper articles and finding things about just the prevalence of concerns. So we are finding, obesity size chairs in waiting rooms, more and more children dying of obesity-related complications. The clothing for children have now plus sizes. So it is a growing problem. Obesity is a global issue. It is a very American issue as well, but it's also global. And it is not only changing healthcare, but marketing. So many layers of our society is obviously being affected. When you think about just overall obesity, we know that when polled, this 75% of American adults are worried, concerned about obesity. So I say that this is important because when you think about obesity, I want you to realize that people are aware of it. People kind of understand what causes it, but the vast majority of our society, as you see here in these stats, you realize it's a public health problem, but why is it that people are not doing things to change it? So it's definitely, when we look at, even though this is not a master's in public health, I have had students move on that way to go into looking at public health, the public health program. But from a public health perspective, this is a population-based health, so it's not just one cohort or one specific link of a genetic trait. This is a population-based problem. You all know this stuff, right? So it says it's linked to many chronic health problems, premature death, diabetes, hypertension, heart disease, stroke, all of this stuff that you're really well aware of. So we know that the more adipose tissue we have, on our body, that the link to cancer, early death, morbidity, heart disease. We'll talk a little bit more about this, but I think we know that link of being unhealthy. So these consequences, it's important for all of us to realize that these important consequences we understand with adults are the same things for children, right? So children too used to be, it's okay, Johnny's got baby fat, he's, just a chubby toddler, and all of a sudden Johnny's a chubby middle schooler. It's not okay. Too much fat is too much fat. It definitely changes the way our organs work. So I want everyone in this class to kind of let that sink in. Fat children have the same consequences as fat adults. It is the same problem. Now, it does take years for those consequences and comorbidities to set in, but it's definitely it's not safe. So the persistence of obesity, 15% of overweight infants, 25% of overweight preschool children, 80% of obese adolescents, 10 to 14 years old, with at least one obese parent. What do we know with these stats? Become overweight adults. So, the little preschooler, little Johnny with too much fat when he's 4 or 5 years of age, right? That's going to persist. Persist into adulthood. This is interesting. So let's look at these numbers. It says that percent of children age 5 to 10 with one or more risk factors for heart disease. And there's a list of what those risk factors could be, right? Blood pressure, cholesterol, all of these things. That's about only 27%. Look at children ages 5 to 10 with 2 or more risk factors for heart disease. Much, much less, less than 7%. When we factor in the word overweight, so now we're looking at children 5 to 10 years of age with one risk factor, 60% of these children. When you take a look at 5 to 10-year-old overweight children with 2 risk factors, that went from 7% up to 27%. So we go back to that slide that there's consequences for kids, right? We see this, we know this. This is another slide. It's kind of awkward because the purple line isn't green, but let's take a look at the percentage of overweight children and adolescents over time. So not too sure when you were born. I don't know, my thinking is you're probably around 20-ish, maybe a little older. So if you kind of take a look at the upward swing in the 60s through the 70s, right, what are you looking at? You're looking at the different ages. So, you know, somebody, however old they were, and on the purple line, ages 6 to 11, that very increase, right? Something happened kind of the beginning of the 80s and moving on with this upward tick. It's very similar timeline with more older adolescent children, between 9 to 12 at that time, upward tick. So for the last few decades, it's been a very rapid incline with obesity. So we are dealing with a generation of at-risk children. So today's children are going to have a shorter life expectancy than their parents. 1 in 3 will develop diabetes, right? So the risk of sustained, let me back up. They're going to get diabetes before they're adults. We have so many children right here in the city of Akron, Akron Public Schools, where we now screen children for, it used to be called type 2 adult onset diabetes. They kind of dropped that language. It's just type 2 diabetes, right? Because we realize that our children are getting this. So developing diabetes, risk for sustained overweight rises from 20% at age 4 up to 80% at age 16. That's a pretty heavy result. Childhood obesity persisting into adulthood is associated with more severe health risks. Overweight young adults between 5 to 20-year-old, again, a decreased lifespan. So when you look at a child that is overweight, their blood fat disorders or lipids, cholesterol disorders, fatty liver, right? So a fatty liver, cardiovascular disease, early onset signs of heart disease are things that you once would see in middle age and on. We're now beginning to see that in children. Type 2 diabetes, 10-fold increase in the last decade. Again, I just mentioned Akron Public Schools, our local community, and what kind of screening has to happen. Obstructive sleep apnea, these are things that usually, you know, your old overweight uncle may suffer from. Now children are having this. Asthma, joint disease, polycystic ovarian disorder, which is a very difficult disease for women, right, with hormone imbalances that are due to fat. Gallstones, psychiatric disorders, lots of mental illness that comes from the level of having too much fat. There's a big link. So to be classified as overweight, we look at childhood obesity a little bit different. So for adults, we're looking at BMI, right? Classic just BMI, right? BMI greater than 30 for adults. When you're looking at children, we're looking at height and weight charts. We call these growth charts, and they put them into percentiles. So you may recall yourself, depending on your age, you go to the pediatrician and they do your height and your weight, and the doctor would usually graph that. So 95th percentile, based on the growth charts, is how the definition of childhood obesity. So if you're looking at just BMI, example, you know, how much they weigh versus, you know, how tall they are, it's rising. Excuse my yawn. So we know that obesity is rising. We see this. I'm guessing you've seen these slides, but I love to show them because I think it just really sets in to the prevalence and the power of what all of you have with making good impact on other people. So let's just kind of quick through this, right? So the last few decades, so beginning in 1990, you see how many states are 10% or higher. So the colors are 10%, 10 to 14%, 15 to 19%. Then we fast forward, and now we begin to see a little bit more in the 15 to 19% of the population. These are adults that are overweight, right? So this would be an adult with an overweight. Now, as I just quickly go through this, right, I'm just going to go through there the first 5 years. Wow, look at how many states are almost 20% classified as overweight. Keep going, right? Now we're going right through late 90s. We now have another category of 20 to 24% obesity. So now you're looking at what are the states that we are seeing rapid growth of obesity. So we're going to keep going. You're going to see these orange slides really take over. So again, I'm not too sure what year you were born, but you can take a look through your lifetime. Now here we are in the beginning of 2000. We have another category which is greater than 25% of the population being overweight. recognize the states that you see these in. There's a link between education, socioeconomic status, access to healthcare, basic education that comes into play as well when we begin looking at the states that are beginning now. Look at how fast this is. We now have another category of over 30%, right? The black with the little dots on it. So I should update these and put in even more, but it's just now widespread, right? So the volume of obesity is ridiculous. So we've got an economic impact. These numbers are billions and billions. I could look up, 2018, I think were the last ones I saw. So we have billions of dollars being spent not only on obesity, but on pediatric obesity. So in pediatric obesity in the 70s, 35 million. Jump it to a couple of decades ago, 127 million. Fast forward to today, it's almost doubled. So when you look at it being preventable, right, we've got this scale, and these are things you know, right? How much are you intaking, your energy intake, food, beverage, sugary foods? How much are you expending, right? That energy in, energy out expenditure. So every extra 100 calories will put on 10 pounds per year. Let that sink in, right? This is what we call creeping obesity. For every 100 calories consumed per day, by the end of that year, it's going to be 10 extra pounds, right? You might know of the freshman 15, right? What happens when this, freshman ends up on college campus, right? There's this food. This is happening, creeping obesity is happening everywhere, and it's food-based, right? Taking in too much food. So 3 factors are related: poor diet, inadequate activity, not doing enough, and just overall decreased inactivity. There's been studies on looking at how this has changed so rapidly, looking at what we feed infants and toddlers. This study taking a look at increased calories, so 25 to 30% of young kids, right, 9 to 24 months old, less than 2 years of age. That's my dog scratching in the background. So are eating no fruit and no vegetables. Okay, so think about if they're not eating fruit and vegetables, what in the heck are these kids eating, right? Processed food. The number one veggie for 15 to 24-month-old, okay guys, these are kids under 2, right? They still maybe wear diapers, right? 2-year-olds. Number one veggie is a French fry. Among children 19 to 24 months, 44% are drinking sweetened drinks. So this is fruit punch and juice boxes and orange juice, right? All of that is unneeded. I agree it tastes good, but it's not needed, right? No one that's not even yet in school under the age of 5 should be consuming any sugary product, right? They should be drinking water and more water, right? Milk, water. So the sugar, right? Candy, desserts, 69%, hot dogs, bacon, sausage, 27%, salty snacks, 27%. This is just one of many studies that why are we seeing this problem with kids that are so fat? It's what we're putting in, right? The food, that's a huge piece. So look at that etiology. The caloric intake has increased. Why? Eating unsupervised, lack of sitting down at a family table and eating a meal that's been cooked, eating at multiple different places. There's kids are eating snacks everywhere. There's cupcakes at a soccer game, and everything about a children is let's feed them with ice cream and cupcakes and cookies. Lots of eating out at restaurants, fast food. And the beverages, as I mentioned, beverages are really toxic. They're just full of calories, right? We should not be drinking our calories. We should be eating our calories. And then really calorically dense food. So we have lots and lots on the food side. Obviously, this is for exercise. Inadequate physical activity is a really big problem. We have seen across all public schools in the nation a cutback, and I have articles we might be able to read on looking at this problem of physical activity being eliminated, after school programs being eliminated. Parents are afraid to let their kids out in the neighborhood for fears of safety and crime. So the results are they're inside their home in front of the television, in front of video games, right? This fear of society, right? This kind of very violent, kidnapping and abductions, and so there's this fear that people have about being outdoors, riding your bike, playing basketball outdoors, and then we have the flip side where they're even in the school in a safe spot where they should be getting activity, it's being cut back to be pushing more of the academic focus, right, to meet all these testing guidelines. So more time spent than ever before at watching TV. So the average is 2.5 hours a day, but we're seeing way significantly above that. BMI and obesity obviously is associated with higher TV watching. I think all of us are probably guilty of that during this pandemic. We're all at home, but really being aware of how little your neighborhood you live in are you seeing kids outside playing? Probably not. Higher cholesterol levels when we're watching TV, because our body, the more you sit, the more you can't process through the food, right? We're not uptaking all of that LDL levels. And then the other problem is how many children have an electronic device or a television in their bedrooms, right? Because this just leads to more TV watching. So lots of problems with activity, and again, even more so in the last year with COVID. But just kids are not moving, and our society is not moving, and our ease of technology with how easy it is to change the TV with a remote, how easy it is just to sit and virtually play with your friends, right? If you're a kid on the computer versus going outside and meeting them on a bike and going somewhere, right? So these photos, you've seen them, they're just the society we live in, right? Lazy. Right? There's a lot of lazy, easy access, moving sidewalks, escalators. So this framework of what do we do, right? So we can talk forever about the problem, but what do we do? So we've got individual factors. We have who are they? The genetics, the psychosocial, who are they personally? Then we've got this behavioral that we really want to focus on. So their home, who's in their family, what kind of behaviors do the parents and siblings have, what kind of community are they living in, what do they have access to, a local swimming pool, local basketball court, work site, health care. Do they have health care? Are they going to see the physician? And then the sectors of influence is all of these things that many of you may end up getting a job in, right? So the food and beverage industry, who are they marketing? What's the quality of the food we're eating, right? There's lots of studies that are looking at American corn, right? Corn is pushed in a lot of our food, and there's lots of stuff you can read about the corn problem. Education, right? How many people really know how to read a label? How many people really understand that fad diets don't work? And how many people really understand that giving your child a Happy Meal is not healthy? So government, public health, all of these sectors I have listed on here is factors that are going to influence this. But we really have to find a balance between the genetic, the low metabolism, poor appetite control, low fat-free mass, right, so it's muscle, low levels of lipid oxidation rate, so all of these kind of physiological things in the green. And then the purple is their environment. So their environment, their home life, right? How much are they walking? How much are they moving? Do they own a bicycle? Are they allowed to go outside? Are the parents active? What kind of food is in the fridge? What do they have access to? Are they going to a grocery store to shop? Are they just shopping at the local convenience store that's not going to have the fresh food? So I want you to think about children and that they are a product of the family in which they're in, but we're beginning to see in the last couple of decades this obesity is really on a rampant upswing with children. So behavioral goals is to promote lifelong healthy eating and activity, and then medical goals. We want to prevent these complications. We don't want them to be exposed to adult problems. So improving and resolving these complications is a really important thing. How do we treat them? Well, number one, we want to prevent it. But to treat it, we need to get at weight maintenance. So between ages 2 and 7 years of age, once they start seeing at those yearly visits to the pediatrician that the growth charts are going up too high, right, their BMI percentiles, we really need to intervene. It's not okay for the pediatrician to not address the diet issues and the exercise issues right in there with the parent. So this is an important thing with how do we intervene and how do we not let it lead on to full-blown obesity. So 7 to 18 years of age, again, complications, weight loss, how do we treat this? So evaluation is history, physical, and then lab results. Their values are going to be right in the blood work with their lipid panel, right? Their cholesterol, fasting lipids, glucose, which is going to be a direct link, obviously, if they're going to have diabetes, hemoglobin A1C. They can look at thyroid stuff in kids, but usually right there with the glucose and the cholesterol is going to be paint a really good photo. Treatment is to educate, and this is always the problem because it depends on the parent's mindset and how willing they are. So assess the family's readiness to change, mom and dad, what are they doing? What kind of lifestyle are they eating? Because the treatment needs to be a family, right? The kid can't shop and cook their own food. So it really, we have to figure out the pecking order of what part of the family aspect can we begin doing interventions and treating them. So for a child who will not be entering formal obesity clinic, right, then we want to just talk about TV watching. Don't eat in front of the TV. Sit at the table. Give them a meal on a plate. Portion size it. Don't leave the food on the table for extra heapings of food. Eat as a family. Go for a walk. Get a dog. Go to the park. If you're going to be video gaming, have active video games. And then stage 3 is when we begin doing caloric restrictions. So hypocaloric diets, really beginning to look at exactly where those nutrients are coming from. And then a formal approach is what we would do if any of you to work in a clinic. And at the end of the slide, I've gotten some local clinics around town that have obesity with children. So physician, therapist, dietitian, and the exercise physiologist. Intensive program where you are going for education sessions and having an intervention and learning things. So formal obesity clinics has a lot of advantages. It's physician oversight, and when you have a physician on board, a lot of people are more willing to stick with the plan because there's something about letting a doctor down we just don't want to do. So think about that night, the difference between going and trying to do this on your own versus having a weigh-in and going and sitting at the pediatrician's office, because you usually get better outcomes. There are some medicines, and I'm not going to go too much into these medicines. Later on, I may bring in some of the more current medicines. I want you to just let your eyes go all the way to the very last bullet. How much weight loss do you really see with any of these pharmacological, right, prescription weight loss medicines? Almost nothing, right? 10% weight loss. So yeah, it can help, but is it really going to be that helpful? There are more and more growing trends as our nation is becoming fatter and our children are becoming fatter at opting for bariatric surgery. So some people say we have little information, others say we have enough to get going. I have worked myself with some older adolescents, 16, 17, 18 years old, that have had bariatric surgery. I haven't done anyone littler than that. It's the same procedure as adults. It's very, very intense procedure. It's not a procedure you can redo. So they're completely changing the intestinal tract. Along with the stomach, the size of the stomach. So we really want to, I say, get them to get weight maintenance with lifestyle changes before we end up with surgery. But the nice thing is if they qualify, they pass the psychological exam, they can cope with having the surgery, they have really, really good support system. The child is willing to comply to eating. It's a full different life, right? Bariatric surgery is hard enough on adults. It's a whole other layer for an adolescent. So there's gastric bypass and there's lap band. We're seeing less and less lap band. Gastric bypass for a sleeve is the most common. So vertical banded or adjustable banding, those are okay. More and more are going to do the Roux-en-Y. So we're seeing less and less bands. Much more so it's going to be the actual Roux-en-Y, where take a look at the size of the stomach, right? So look at it's both restrictive and malabsorptive. So your stomach holds less and you're absorbing less. So I'm going to have you read an article for this week's assignment, but locally there was just an article in the Akron Beacon Journal a couple of weeks ago about Akron Children's Hospital weight loss program. The Cleveland Clinic has a weight loss metabolic program for adolescents, and then Cleveland University Hospital. If you're interested, these are areas you may want to volunteer, ask for information, just go and explore. Where are these clients going after they have surgery? What personal trainers are they referring to? What gyms are they referring to? So for this week, you're going to read the ethical issues of pediatric bariatric surgery, summarize and upload by Sunday night. That is the goal for this week.